when we're talking about the confidence in the biosimilar pathway and achieving biosimilarity, a lot of my colleagues and experts in the biosimilars field that I talk to will discuss a biosimilar as being akin to a new batch or a new lot of a reference biologic drug. And the way we talk about that is, we know that since 1998, when the first biologic in rheumatology was approved, that drug is different from the drug that's coming under the same brand name now. It has shifted because of change in manufacturing techniques, often improvements. And we now know with analytical detail and technology that's available these days that a biosimilar might be more like a current reference biologic than that reference biologic is similar to when it started, when it was first FDA approved. And so thinking of it in that light, you can consider a drug that has achieved biosimilarity status, according to the FDA, as a new batch or a new lot of the reference product.
Right. And I was just thinking that since you're a specialist, that might be something that you would look one step further to figure that out. But for the average healthcare provider, and would they be looking at this from the perspective of all the history with small molecules, where you have a generic drug which has an exact ingredient that's identical, and that they say, yes, a pharmacist can actually make that substitution, and the interchangeable is really kind of the biologic version of that, whereas the biosimilar is just another product. So, in some ways, if you're looking at it from somebody who's not digging deeper, doesn't it somehow make it sound like the interchangeable has been blessed by the FDA as being safer or, substitutable for this product?
Yeah, I mean, I think that's I think that's certainly part of what some people are thinking. I think the FDA has made it very clear in their thinking that that is not true, that it's less safe, because of course the hurdle for biosimilarity is where you determine whether the product has enough of the analytical similarity to be considered similar. But I definitely agree that there will be that perception, and I think that in part, that's why in Europe they don't have the designation of interchangeability. And the reason for that is because they believe in the science of biosimilarity and leave it up to the individual countries to decide. And hindsight's 2020, right? We're only 7 years in the U.S. But I think thinking that there could be a perception that an interchangeable is a higher quality or higher level of safety or efficacy is incorrect. And I think the FDA will continue to try and reiterate that. The reason why there are two different designations is they're proving two different things. So I think that it's a worthwhile point, because I think stakeholders will, as they learn more about it, could naturally go to that. And the truth is, it's a different pathway and it's a different approach from small molecules for many reasons, the least of which is the complexity of the molecules.
Molly brings up Europe, and I think that's an astute observation. The difference between the biosimilar pathway and the interchangeable pathway is probably in the eye of the beholder at this point. For me, biosimilar designation means that a drug is expected to work as well and have the same safety issues as a reference product. Like I said, a new batch of the old reference product. On the other hand, I think interchangeability is an excellent idea in the multi-payer, multi-state market like the United States compared to Europe, because patients that I prescribe drugs for can be expected to move, change insurances, graduate into Medicare, or their formulary of their same old insurance might change year to year. And so they may actually expect to switch back and forth from a reference product to a biosimilar. And so I'm thrilled that the FDA proposes to study drugs like that.